Okay, the next candidate يا شباب.
Assalamualaikum, sir. I'm candidate 5.
عليكم السلام ورحمة الله وبركاته. How are you, my friend?
Alhamdulillah, sir. Jazakallah.
Alhamdulillah. Okay, you can start. Abdominal pain. What do you see?
I've been presented with X-ray abdomen of a skeletally mature patient. In my first glance, I can appreciate there is a gross, centrally placed bowel wall dilatation. In few of them, I can see complete vulvic conventives, making it a small bowel obstruction, which is placed centrally. I am also concerned for some linear lucencies that are appreciated in one of the topmost ball, centrally placed bowel wall loop, and it's concerning for pneumatosis. I'm also concerned
Good
for some
point.
linear lucencies that are seen in branching linear lucencies that are presently
You're
seen in the
suspecting.
right.
Good.
I
Good.
also suspect some linear lucencies in right upper quadrant that may be presence of that may reflect the presence of pneumobilia or
How to
protovenous gas.
confirm? How to confirm? Just
Uh,
upper abdominal radiograph is needed to include the lower chest in erect. Okay, good.
sir, I would like to ask a request for an upper abdominal radiograph to include the
Good.
diaphragm to look for subdiaphragmatic air. I cannot appreciate any metallic densities to suggest
Good.
presence of surgical staples. The pelvis is relatively clear without any evidence of any calcific. A few phleboliths are appreciated, however, no major other calcific density is appreciated. I can appreciate the surgical replacement of the right hip joint.
Good.
Background bones show degenerative changes, so this is a skeletally mature patient. Considering this, I would immediately pick up the call as this is a
Do you
small
need
bowel
any
obstruction.
other radiograph? You said upper abdomen radiograph. Do you
Upper
cover the
abdomen
hernia
and lower
hernial
abdomen to rule
orifices
out.
covered or no?
Sorry, sir.
Hernial orifices covered or
Hernia.
no?
I would also request an extended radiograph of the
Good,
lower abdomen to include hernial orifices.
good, good. Then finalize small bowel obstruction, possible cause 1 to 3, and I need CT scan. Don't forget, please, hernial orifices. It's very important in the exam. You mentioned surgical clips. You suspected air lucency here. No radio opaque shadow. I want upper abdominal or lower chest radiograph in erect position to
Sir.
assess liver and rule out any pneumoperitoneum, as well as extended view of the pelvis and hernia orifice. Very good, my friend. I'll give you, this case is easy, inshallah.
Sir, I have
Can you,
requested the
can you,
control.
yes. Okay, you can scroll.
I'm trying to scroll the screen. Yes, I'm able to scroll. I'll try to scroll the given stack of images from top to bottom. In my first glance, I can appreciate stomach is grossly dilated. There is also gross dilatation of small bowel loops, which are
Good,
partially air and fluid filled. Till now, the wall appears adequately enhancing.
good, very
The
good.
kidneys and the central abdominal vessels appear unremarkable. I could not appreciate any gross abdominal fluid, but I would be commenting on ascites in my last tag to rule out any small pelvic fluid. Um,
So what you are looking
I,
for?
I'm also looking for any calcific gallstone to rule out any gallstone ileus. I'm also looking
Good,
for any anterior or lateral abdominal wall hernias.
good.
This scrolling is taking a moment. I'm trying to scroll down to rule out any inguinal, femoral, or obturator hernias.
Any mass inside or outside? Okay.
Any
Any
mass.
speculated appearance? Any surgical clips? Good, good.
So I'm trying to scroll till the last bit, and then I'll start. So in my, I can appreciate there is. I can appreciate an extra abdominal protrusion of the bowel loop in the right obturator canal, extending
Show
between
me,
the
show me.
obturators over this part.
Use the pointer, please. This is
Yes,
the
this is a
obturator.
sir. This is a fluid-filled loop that is extending outwards, and when I trace it backwards,
Okay. It's not
it's
related to the obturator. Go down, go down. I'll show you the obturator. Go down, go down, go down.
yes,
يعني
it's not related to
okay. So what is the type of this
this is
herniated
related to
bowel loop?
the yes, it is related to the
It's lower abdominal wall
lower
hernia.
abdominal.
Good. This is a general term. Can you decide what or specify what type? It's not
Sir, it is
obturator,
medial to the vessels and superior to the pubic ramus. So, inguinal hernia, right inguinal hernia.
right? Inguinal hernia. So inguinal hernia, you mean indirect, correct?
Yes, sir.
Is it lateral or medial to pubic tubercle?
It is medial to the vessels, superior to the pubic.
I said pubic tubercle. It's lateral. It's lateral to
Lateral,
it.
yes.
Okay. Can you determine its relation to the vessels? What is the
It's
effect of this hernial sac on the vessels?
sir,
Give me
it's
the vessels.
medial to
Give
the
me the vessels.
vessels.
Okay, I'll take control after permission. I'll take the control back. Okay. So from the start, I will finalize it later. From the start, you have very good start. Okay. Regarding the radiograph, it's a small bowel dilatation. I need upper abdomen and I need lower pelvis. Upper abdomen in erect to rule out free air and to assess and confirm this possibility. Is it branching lucency? Yes or no? Because I don't see the liver accurate, liver shadow. No radiopaque shadow, no surgical clips, evidence of hip replacement, and I need to see hernial orifice. Very good approach. Now we have in this contrast study dilated stomach and small bowel, but please comment on the visualized part of the liver. Okay, in the
Sir.
limited visualized part of the liver, I don't see any branching lucences to suggest portal venous gas or pneumopelia, and the gallbladder is intact. It's important to mention these points. Tell the
Sir.
examiner, I know the causes and I want to rule out the causes one by one. So no portal venous gas, no pneumopelia, normal gallbladder, normal enhancement of the portal vein and the mesenteric veins, dilated bowel loops. Very good point from you. It's normal wall enhancement and normal thickness. Very good. IVC looks of average caliber. Why? It's not shock syndrome, although compressed here, but usually, mostly of a normal caliber. Good. Down, no free air. Yet in my routine practice, what you will do?
To the lung window. I'll convert it to the lung
Yes,
window and rule
very
out any
good.
small limb.
Very good. Very good. So you assess the vessels, you assess for pneumoperitoneum and no pneumatosis. Now to the transition point. This is the transition point. So it's a hernia. Okay, what type of hernia? It's a groin hernia. You see this part. It is not medial, it's lateral. Okay, Dr. Ismail, lateral means what? See the vessel here and here. Artery, artery. Vein, where is the vein? Where is the femoral vein? Collapsed.
Right,
Okay,
sir.
collapsed. So this is definitely femoral hernia. It's femoral. The most sensitive sign, in addition to lateral to the pubic is the compression on the femoral vein. Femoral vein, its size either similar or larger than the artery, not smaller, not collapsed. So it's definitive a femoral hernia. This bowel loop containing fluid and the hernial sac also containing fluid. So it's obstructed femoral hernia. What about the obturator? Obturator should be here. You
Here,
see,
yeah.
this is the pectineus, and this obturator externus and internus. This is the location of obturator hernia. It should be here, beneath, deep to the pectineus, not superficial. Superficial to pectineus, other groin hernias, like inguinal or femoral. But obturator should be here. Again, it's a surgical emergency, no hypo enhancement. It's average enhancement, so no ischemia till now. Okay, so it's
Thank
obstructed femoral hernia. Very good, my friend. Very good.
Thank you so much, sir. Jazakallah.
Welcome, 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 my friend. Okay, the next candidate, easy case. So I'll give you another one. I'll give you two cases. The next candidate is lucky. Huh?
Assalamu alaikum, sir.
Alaikum assalam wa rahmatullahi wa barakatuh. Okay, I'll give you the control. Can you ask for it?
Okay, sir. Requested, sir.
Okay, okay. I will give you start the timer as well. Abdominal pain.
Okay, I'm presented with the non-contrast CT scan with the oral contrast. Okay. First thing which I noticed that there is right-sided pleural effusion.
Scroll is better, yes.
Okay. I can see that the oral contrast is seen opacifying the stomach and the small bowel loops.
Dilated or no?
Sir, it's not scrolling. Actually, it's scrolling very fast. Okay, the small bowel loops does not appear dilated. Okay. Sir, it's not scrolling. It's very fast with my mouse. I'm trying to scroll it through mouse, but
I
still.
will take it. I will take it. I will scroll. I will scroll. Okay. Just give me the mouse. No problem.
Okay, sir.
Okay. Starting from up. We have some dilatation. Okay. Fluid-filled bowel loops.
Okay, yes, sir. No
Okay.
pneumoperitoneum. I didn't see any air under the diaphragm.
Okay. So we suspected some sort of obstruction. I'll give you another case, by the way. And we have incidental finding here. Okay. Don't forget this one. Okay. What is this?
Abdominal aorta.
Aneurysm. Abdominal aortic aneurysm. This is
Yes.
dilated. Okay. So,
sir, I can see that the calcification which were noticed in the lumen of the aorta slightly appear to be displaced.
okay, I'm suspecting bowel dilatation. I'm
yes, sir, there
suspecting
is
bowel
in the
dilatation.
right,
Okay.
yes, sir. In the right iliac fossa, I saw that there is a protrusion of a viscus. I think that is related to the bowel loops. I would like to trace it back to make its connection. Okay, it is noted with the obturator fossa. I think this is
yes.
most likely to be an obturator hernia.
Okay, this is a classic, my friends,
is
obturator
located
hernia. I'll give you another case. This is a classic obturator hernia. Okay, you see now, obturator internus, externus, pectineus. This is a classic location of obturator hernia. It's a common exam case, very common exam case. Okay, you see this bowel loop, the up, 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 oh, here. So this is a transition point. Okay, and again, no significant mural thickening, clear surrounding fat plane, so it's obstructed, but unlikely strangulated. And again, in my routine practice, I will check the lung window and I check the vessels and in a contrast study, of course. Okay, so this is obstructed obturator hernia. What about the next one? Concentrate abdominal pain. I'll scroll for you.
Okay, so first thing which I noticed is that there is dilatation of the small bowel loops, and I can also see air within the bowel loop walls. So,
Good.
which is
Very
most
good.
in pneumocystis intestinalis. So, I'm suspecting that there is ongoing obstruction as well as some ischemia. I can see that there is free fluid around these bowel loops. In my routine practice, I would like to trace them to find out the transition point. I can see that the oral contrast is seen within the stomach. Okay. And in the pylorus,
It's a
the first
difficult
part,
case.
I would
Okay. The previous
okay.
case was easy, but this one is difficult.
Okay, sir. Okay. I can see that there is some twisting of the
Good.
mesentery in the
Good.
mid-abdomen, and the small bowel loops are seen converging towards the left side of the abdomen,
Excellent.
central with a small transition point or the nipple like structure. So I
Good.
feel like this is secondary to herniation.
What type of hernia?
Uh, Sir,
General term, just general term.
okay.
Internal hernia.
Sir,
It's
internal hernia, yes, sir.
internal hernia. Yes.
Internal.
The previous covered
Yes, sir,
cases was
internal.
external. External hernias. External hernia can affect the groin or abdominal wall, like sphenian hernia, like umbilical hernia, like lumbar hernia. All these types of hernias considered external hernias. But here, very good. We have a clustered bowel loops. Clustered bowel loops and having its mesentery radiating to the center across the abdomen. And this clustered bowel loops looks dilated, fluid filled with pneumatosis intestinalis. Excellent, my friend. Excellent. So,
Yes, sir.
what happened here?
Sir, I would like to see I would like to see the relationship of the SMA and SMV and
Closed loop obstruction is accepted term, by the way. Internal hernia can be described as a closed loop obstruction. Very good. I'll give you a little bit difficult hint. This can be, what is the commonest type of internal hernia?
paraduodenal hernias.
Excellent. Paraduodenal hernia. Very good. Do you think this is a paraduodenal hernia? Yes or no?
Sir, it can be paraduodenal.
Okay. Any one can answer yes or no? Paraduodenal hernia. Yes or no? I know it's a difficult one. No problem. Yes, yes. So all of you said yes. Okay, okay, no problem. The next one. What type of hernia? Is it paraduodenal? Yes or no? Leave the annotations, please, my friends. This is another case, but not obstructed.
Sir, I can see that all of the jejunal loops are on the one side and the duodenum
Good.
appears to be on the right side. So this, I think this, it doesn't look like to be paraduodenal.
No, this is definitely paraduodenal.
Okay,
Okay,
okay, yes,
this
sir.
is definitely paraduodenal. Why? We have important clue, my friends, the outer contour. The outer contour of this clustered bowel loops is smooth. So this bowel loop is clustered within a sac. It is contained within a sac. Okay? If the right-sided or left-sided hernia is contained within a sac, then it's paraduodenal hernia, in addition, of course, to the vessels. But I'm relying on the sac. The previous case, you see here, I can see the lobulated outline of the bowel loop. It's separable. So it is not contained within a sac. The hernia, the paraduodenal hernia should be contained within a sac, but this type of hernia is not. So this one is not paraduodenal hernia. Actually, it is located posterior to the stomach, and
Yes.
it's opening between portal vein and IBC. It's another type of hernia. Do you know this type? It's not paraduodenal hernia. It's called lesser sac hernia. How to differentiate lesser sac hernia from paraduodenal? Look at the periphery and the location also. The periphery, if you see lobulated outline, no sac around. And of course, higher location posterior to the stomach. But this hernia, it's contained within a sac and lower down, below the level of the stomach, in addition, okay, to the vessels. So this one is paraduodenal hernia, and this one, lesser sac hernia. It's not essential to determine the type of hernia in the exam. But the complications, you passed this case. Since you diagnosed it as ischemia, you passed this case. Okay? But some clues are important to reach the full mark. Okay, thank you, my friend. Thank you. So we covered now some external hernias and some internal hernias. Now to the last group of cases, candidate 7 or 8 present.
Yes, sir. Yes, sir, I'm here.
Okay, how are you, my friend?
I'm fine. Shukr, alhamdulillah, sir.
Alhamdulillah. Okay, do you want to ask for control?
Okay, sir.
Okay,
Sir, I have asked for it.
okay.
Yes, sir.
Just mention the finding on a CT scan on this plane, then I'll give you the CT. What do you see?
Okay.
Abdominal pain.
Sir. Okay, sir. Sir, I have been provided with a scanogram image of a adult patient for which the CT has been done. On this scanogram, I can appreciate that there are multiple dilated small bowel loops which are identified within the center of the abdomen, which are concerning for intestinal obstruction. I cannot appreciate any air within the distal bowel loops, and I cannot appreciate any air lucency projected over the liver shadow in this particular scanogram. I do not appreciate any free air under the diaphragmatic contours. The hernial orifices are not clearly covered in the scanogram, so I would like to correlate my findings with the corresponding CT. And I don't see any surgical clefts, which might signify any prior history of surgery. So I would like to move on to CT for evaluation of any particular cause for this intestinal obstruction, and I would like to urgently inform my referral for these findings.
Okay, I will give you now. And this started. You can scroll.
Okay, sir.
No need for the chest. Start from the abdomen. Okay, go down.
Okay, sir.
Okay.
Okay. Yes, I can scroll the images. So I would go down to the level of abdomen. Okay. I have been provided with the CT abdomen for which the X-ray showed dilated bowel loops. On this, I would like to explore my set of images before I can comment on the findings. Okay, up till now, I can find multiple dilated small bowel loops in the center of the abdomen. So I'm going down for looking for any mechanical or any iatrogenic cause of this obstruction. Okay, I would like to go down. Okay, I have moved up till the last stack of images, and I can't appreciate any protrusion of the bowel loop through both inguinal or the femoral hernial sac. Oh, sorry, sir, it's a little bit too fast. I'm sorry. I just jumped the upper one. So I
any transition point you detected?
Sir, this one over here, I think it's at the level of the terminal ileum because I can appreciate a small bowel feces sign as well.
Good. You can go up. You can go up because
Sure,
I see also small bowel feces sign. Okay. Yes.
I don't appreciate any. Okay, there is. Sir, there is this transition point seems to be over here. So
yes, close to this area. Close to this area. Okay, go up.
And there is some fluid with it as well. There is some. So there is this area.
Yes. What is this?
So there are some calcific areas within it.
Excellent. Go down. Good.
Sir, I don't appreciate any.
Show me the calcification.
Sir, this
very good.
Yes, sir. So this is concerning for a carcinoid kind of thing, sir, but I don't appreciate any desmoplastic reaction, which might be causing the retraction. So, sir, the finding.
So it's a mesenteric mass. It's not
yes,
bowel.
sir, this is a good. Yes, sir.
But it's adjacent to the bowel.
Yes, sir.
Close to the transition point.
Yes, sir. Yes.
Good.
And I can appreciate small over here. I can appreciate, sir, there is significant amount of fat stranding, and there are small volume reactive appearing lymphadenopathy, which is also appreciated.
Good.
And over here, sir, at this point, it might represent some kind of retraction of the mesentery. So sir, I am
which
now
can
getting.
be assessed in other planes like sagittal or coronal. In my routine practice, I will check for them because desmoplastic reaction can be seen better in other planes. Good. What else you should look for in this case?
Sir, I will now clearly look at the small bowel for any primary focus because
Excellent.
mostly the mesentery is the second focus for the carcinoid, and then
Excellent.
it has got association with the familial adenomatous polyposis syndrome. So I would also like to go for any polyps which I can appreciate in the small bowel
Good.
loop.
What
The large
else?
bowel loop. Sir, then I would look at the liver for any metastatic deposits.
Excellent. Excellent. Okay.
And so then,
So,
yes, sir.
and of course, again, lung window to detect any perforation. So, what is your final diagnosis and next step of management?
Sir, my most likely diagnosis is that of the carcinoid tumor, which is causing the desmoplastic reaction with resultant small bowel obstruction, no perforation at the time of the study, and no metastatic focus noted at the point of the study. So I would like to convey my findings to the referral. I would like to refer the patient for DOTA-TATE PET CT, and then I would like to refer the patient to neurocrine tumor MDT for further evaluation and management.
Excellent. What type of nuclear study can be suggested?
So that would be 111 indium octreotide or DOTA-TATE PET CT.
Excellent. Octreotide scan or DOTA-TATE PET CT, not FDG. Very good, my friend. Very good. So in this case, my friends, as usual, we have some bowel dilatation. But again, my friend, from the start, you noticed bowel dilatation, just little any information about the liver. No branching lucences, no portal venous gas, no pneumopelia, normal gallbladder. Don't forget these points because gallstone ileus is a very common exam case. And you need to rule out this possibility on the first few cuts. Okay?
Okay, sir.
Normal enhancement of the wall, no thickening. And in this case, as our friend said, no focal hepatic lesions could be seen yet. In my routine practice, I want to check for this in the arterial phase because carcinoid usually send arterial enhancing metastasis. Also, no masses within the bowel because mesenteric carcinoid usually secondary to ileal carcinoid. Very good, my friend. Very good. Okay,
Thank you.
the last case and last candidate.
Hello, sir. Assalamualaikum.
Alaikum salam wa rahmatullahi wa barakatuh. How are you, my friend?
I'm good. How are you, sir?
Alhamdulillah. Okay, you can start with the radiograph. What do you see?
This is X-ray abdomen, supine view. There are multiple dilated small bowel loops seen in the center of the abdomen, giving this type of point appearance. I cannot appreciate any air lucencies in the liver. I would also like to, in my normal practice, I also like to see the hernial orifices, the lower cuts to look for the any lucencies. There is no evidence of surgical staples. And
no radiopaque shadows as well.
No
Okay.
radiopaque shadows and no pneumoperitoneum. I would also like to see the erect. Sorry. Yeah, no, this is an erect.
This is erect.
So this is an erect. And so.
But it's
findings
good.
are
It's good.
suggestive
Keep
of
it in
small
your
bowel
mind.
obstruction.
You have good approach. Very good. Very good. Even if you face the supine first, ask for the erect and including both diaphragmatic copula. Here the pelvis in a supine, but I need little bit more down to check her neurosis. Very good.
Check for
Now
that.
CT
So it's likely small bowel
scan.
obstruction.
You want to ask for control?
Yes. Yes, sir. I have requested.
And I accepted. Okay.
Thank you. So this is CT scan axial section.
Scroll.
I should use, it's going so fast. Okay, so this is CT scan abdomen, venous phase images. I can not see any air lucencies within the liver to suggest portal air in the portal vein or the biliary tree. There
And
is
the
NG
and
tube
the gallbladder
seen in
looks
situ.
normal,
Yeah.
except for
Gallbladder looks normal. There is cholelithiasis seen.
yes.
So there are multiple dilated bowel loops are appreciated in the abdomen. I would like to scroll to the last cut, and then will give my finding. So yeah, I cannot find any inguinal hernia or the obturator hernia
For femoral, very good. Or
in these
abdominal wall
images,
hernia in
or
general,
the
good.
or any interior abdominal wall hernias. So now I'm going to the region of interest. The obvious abnormality that I can appreciate is that there is sorry, it's taking a bit of time.
No problem.
Yeah, there is a massively dilated cecum is seen.
Good. So we have a
Yeah,
small bowel
yeah,
dilatation and massively
with
dilated cecum.
dilated
Good.
cecum. With dilated cecum. Now I'm trying to look for any swelling sign to look for the cecal hernia, to look for the cecal volvulus. However,
Good possibility. Good. What else that can dilate the cecum and small bowel?
Any mass in the
Okay, let me
ascending column.
Let me handle. Okay, yes, give me the control. Okay, what else
Yes,
you should look for in generally in case of a small bowel obstruction?
Sir, the causes of small bowel obstruction include I have ruled out the gallstone ileus, didn't find any surgical staples, no evidence of hernia. So now I would like to see if there is any mass lesion.
Good, good. Especially this patient is young or old?
This is an old patient. Yeah,
good,
old
good.
patient.
Okay, you noticed dilated small bowel. What about the large bowel? It's not
Large
dilated.
bowel is collapsed. Yeah,
Good,
large bowel
good.
is not dilated.
So we have
transverse colon is normal caliber
good.
as well. I would like to go down there is circumferentially enhancing lesion is seen involving the ascending
Yes, yes.
colon with adjacent fat strengthening nodularity. I would also like to see the lymph nodes, if any adjacent enlarged lymph nodes are seen. So this is likely a case of a neoplastic lesion involving the ascending colon with a dilatation of the cecum and the bowel loop. I would immediately I would pick up the call, inform the referring physician for the urgent decompression, and then after the emergency management, refer to the oncological MDT for endoscopy and histopathological coordination.
Endoscopy, histopathological, and CT staging of the chest, since I imaged.
CT staging of the chest.
Yes, very good, my friend. Very good. You mentioned you manage this case excellent. When you see a bowel dilatation, first determine the type. Okay, it's a small bowel. Now we have also a segment of large bowel. Oh, large bowel, different type of causes. What is the commonest cause of large bowel dilatation?
Sir, in old age, it's a mass lesion.
Cancer, yes, cancer. Colorectal carcinoma, over 60% of cases, especially on the right side. But if the obstruction on the left side, another cause secondary to the cancer, other than colorectal carcinoma, will be diverticular disease causing stenosis or stricture. Cancer and the diverticular disease can be responsible for 90% of large bowel obstruction. So excellent, my friend. We need endoscopy, biopsy, histopathology, and CT staging. Excellent. Thank you. I'll just spend a few minutes just to revise the approach of small bowel dilatation. First, if you noticed dilated stomach and or duodenum, think of gastric outlet obstruction or duodenal causes. If you notice large bowel obstruction, think of large bowel causes, especially cancer. or a specific type, for example, like sigmoid or cecal volumes from the radiograph or from the scanogram. But if a small bowel dilatation, classic small bowel dilatation, after describing the dilated bowel loops and the mucosal folds and the distribution, it's a small bowel dilatation. What you are looking for, a possible causes. Like what? Surgical clips, number one. Number two, any radiopaque shadow, branching lucency overlying the liver, which may represent, if centrally located, pneumopilia, if peripherally located and extensive, maybe portal venous gas. Also check for any close sign, as in case of inception. Okay, and all hernial orifices should be checked. So please ask for extension of the radiograph to include the pelvis, and extension of the radiograph to include lower chest in erect to detect any pneumoperitoneum. Okay, what are the possible causes in case of small bowel obstruction? We have multiple scenarios, my friends, in practice and in the exam. One of the commonest scenarios, by the way, the commonest scenario in practice would be adhesions. It's not common in the exam. But in the exam, one of the commonest scenarios, hernias. Either external hernias is more likely, or less likely internal hernias. So if you see small bowel dilatation, check the hernial orifices. Okay. One of the favorable cases is obturator hernia. Any type of small bowel obstruction or hernia, don't forget, ask for lung window and comment on the enhancement of the wall, comment on the vessels, any pneumatosis, and so on. So this case, obturator hernia. This one, inguinal, no inguinal, it will be down medial to the tubercle, but here it's lateral with compression upon the femoral vein. It's an important sign. So the first scenario will be hernias, either internal or external. Another scenario, and is relatively common, bowel dilatation and the transition point, mural thickening and hyper enhancement. If you see mural thickening and hyper enhancement, it's an inflammatory process. In the small bowel, it's an inflammatory process like Crohn's or ulcerative, but most likely Crohn's. What else? What's the second point? Look for skip lesions. Yes, I see this on the lower abdomen and another one on the upper abdomen. What else you should ask for? Bone window and lung window. Lung window to detect any perforation and to detect any fistulous communication. Okay, it's a complication of Crohn's. Another point is a bone window. Why? Look for any sacroiliitis and assess the femoral head. Why femoral head? Therapy, steroids, AVN. Okay. So check for any hyper enhancement or any hypo enhancement. If you see a dilatation down to hypo enhanced bowel wall, then it's ischemia. You have to check the blood vessels. So either inflammatory conditions or ischemia cause alternation of the enhancement pattern of the wall. Some other like this one. This one, hypo enhancement and thickening, and we check the vessels. Yes, portal venous and mesenteric venous thrombosis. So the second scenario, assess the wall for any thickening, hyper or hypo enhancement. Another scenario which is very common, intraluminal structure causing the obstruction. Most commonly, stone, lamellated stone. Take care, because gallbladder stones may be less radiopaque than renal stones, and also pneumopedia. If you see branching lucency overlying the liver, most commonly pneumopedia, except if reaching the last 1 centimeter or so extensive. Assess the gallbladder as well, because it's commonly containing a fistula. Another scenario, obstructive mass. Either the mass inside the lumen, like cecal carcinoma or ascending colon carcinoma, hepatic flexure, or maybe outside the lumen. Okay, this is another possibility. Here, malignancy, a cancer, but here a benign, like lipoma causing intussusception. What about this? Tumor, but outside the lumen. So inside the lumen or outside the lumen? Outside the lumen, think of carcinoid with a speculated contour around and desmoplastic reaction, calcification inside, hyperenhancement. Very important to mention, I will assess the liver, especially in the arterial, and I will ask for nuclear and also assess the small bowel for any enhancing mass lesion and ask for endoscopy. Because primary mesenteric, primary ileal carcinoid is difficult to be imaged or detected by CT scan, but it can be detected by endoscopy. So endoscopy is indicated in these cases. This is another scenario, a complicated case. Bowel dilatation due to underlying syndrome. Like what? Oh, fatty pancreas and some increased density in the ileum. It may be, and plus or minus lung changes, maybe cystic fibrosis. Bowel dilatation and esophageal dilatation with basal lung changes. It may be scleroderma and so on. And sometimes containing multiple polyps. It may be familial adenomatous polyposis or Peutz-Jeghers syndrome, and. One of the last scenarios is in children. Children maybe obstruction secondary to hernia, secondary to appendicitis. What about if I see the appendix below? Then it may be Meckel's diverticulitis or interception secondary to Meckel's. These are causes in children, including also mid-gut volvulus, like this case. So specific causes, which is common in children. Also in children or in adult, think of viscera mottled appearance. So start with the signs of small bowel obstruction. Look for the causes in the radiograph. Ask for a CT scan, and on CT scan, try to detect the causes. Extrinsic causes, assess the hernial orifices, external or internal hernia. Bowel wall causes, either hyperenhancement or hypoenhancement. Intraluminal causes, like stone, migrated, for example, gastric balloon or bezoar. And don't forget the congenital causes, Meckel's, duplication cyst, mid-gut volvulus, and so on. Okay, thank you, my friends, for today's session.